Today we'll be talking about skin biopsy techniques. Biopsy means to view life, and that bio means life, and opsia means to view. So biopsy is the literal meaning is to view life. So the term biopsy was introduced by Ernst Besnier in the year 1879. It's a very commonly performed procedure in the field of dermatology. It not only helps in diagnosis but also helps to document evidence of the diseases. A biopsy is a process by which an adequate specimen of the suspected disease tissue is obtained for microscopic and other investigations. So, you obtain a part of the tissue or the whole tissue for concluding your diagnosis, for coming to a final diagnosis, for the microscopic evaluation, and also for other investigations like direct immunofluorescence and etc. A fully developed lesion, which is not scratched and not secondarily infected, is chosen for biopsy. The active edge of the lesion is used. If it's a vesicle, the vesicles which are less than 24 hours, that is early vesicles, are basically chosen for the biopsy. If it's a tumor that you're taking a biopsy from, then the thickest portion of the tumor has to be taken for biopsy. The types of biopsy are, we have shave biopsy, punch biopsy, surgical biopsy, scalp biopsy, nail biopsy. Even the scalp tissue and nail tissue can be biopsied. Indications of biopsy. We have diagnostic, therapeutic, and prognostic indications. That is, diagnostic indication is wherein the biopsy will help us in concluding or coming to a diagnosis, like in vesiculobullous disorders, collagen vascular disorders, infections, infestations, drug eruptions, in inflammatory skin disorders, and benign tumors. In vesiculobullous lesions, like in pemphigus vulgaris, bullous pemphigoid, etc., collagen vascular disorders like DLE and SLE, infections and infestations like herpes infections or any scabies infections, drug eruptions like erythema multiforme, JST, and other drug eruptions, inflammatory skin disorders like psoriasis and lichen planus, benign tumors like it can be skin tags or it can be any other benign tumor. In therapeutic indications, it is as a treatment option also skin biopsy can be done. It is done for small benign tumors such as seborrheic keratosis, poromas, pilomatricomas, small and early malignant neoplasms like actinic keratosis, Bowen's disease, superficial basal cell carcinoma, and granuloma annulare. So here it is done as a therapeutic option. To see the prognosis of the disease, it is done in leprosy and in mycosis fungoides. And so in different stages of the disease, the presentation in biopsy would be different in leprosy and in mycosis fungoides as well. Contraindications. Infection at the site of biopsy is a contraindication. So if there's any infection present at the site of the biopsy, so that's a contraindication. If the patient has any previous allergies to the topical antibiotics that we give or the topical anesthetics, we avoid doing biopsy. Factors which interfere with hemostasis, like the patient has any bleeding disorders or if the patient is on anticoagulants like warfarin, we avoid doing biopsy. In uncontrolled diabetic patients, if the patient has any keloidal tendency or hypertrophic scar tendency, we avoid doing biopsy. And in cosmetically important sites, biopsy is only done if it is very essential for diagnosis. Otherwise, it is not done. In inflammatory disorders, that is in psoriasis and other diseases, the lesion with advanced stage of inflammation is chosen along with the normal skin. In blistering disorders, that is in bullous disorders, early lesions which are less than 48 hours are chosen. In vasculitic conditions, early lesions again is chosen. In neoplastic conditions, we should excise the entire lesion as a whole, including the center of the lesion. In immunofluorescence, if you're sending it for direct immunofluorescence, perilesional skin has to be biopsied here. Mostly it is done in blistering disorders. And face, tibia, axilla, groin, deltoid area, chest wall is usually avoided, for taking the biopsy. In chest wall and in deltoid, they're more prone for going into keloid formation. And healing would be difficult in groin and axilla. Tibia again would be difficult, and face is an important cosmetic site. That's why it's avoided. Anesthesia. Commonly used anesthetic agent here is lignocaine. 1 or 2% lignocaine is used. A ring block or field block can be given into the lesion, or you can also use EMLA, which is eutectic mixture of local anesthesia. That topical preparation of lidocaine, prilocaine can be used. So adrenaline plus lignocaine also can be used, which will help in increasing the duration of the anesthesia and also provide a bloodless field for the procedure of biopsy. But this mixture of adrenaline and ibuprofen needs to be avoided in certain areas like in nasal tip, ears, penis, toes, fingers, and lips. It can cause ischemia of those particular organs. That's why it has to be avoided in these particular areas, and that's a very important thing that has to be kept in mind when you give anesthesia for biopsy. Proper documentation with clinical photographs and written informed consent, of course, is a must before you do any procedure. Techniques. So, firstly, coming to the shave biopsy. Shave biopsy is basically shaving through the superficial part of the epidermis and the epidermis. So the top part, if the lesion is like this, especially in elevated lesion, so if the lesion is like this above the skin surface, a blade is chosen and it is scraped like this, So the upper part of the dermis also can be included while doing this. So that method is called as a shaving biopsy. So the scalpel is taken which runs parallelly to the skin surface, and then the biopsy is done. So lower dermis is intact in this particular case. You can use number 15 blades, razor blades, adsense forceps, or either scissors for this. So the procedure is consent is taken, anesthesia is given. You should stretch the skin along the Langer lines. These Langer lines are the skin tension lines. Okay, so stretch it along that line. The perimeter of the lesion is marked then, and the blade is held parallel to the skin, and the belly is inserted through the skin. To and fro motion of the blade is done, and you harvest the biopsy in the upper dermis. So you make the incision in the upper dermis here. Hemostasis by pressure is achieved, and then the wound is dressed with antiseptic ointment. So basically you take a blade, go through the upper dermis and take out the tissue. The indications, it is done in lesions like in seborrheic keratosis, actinic keratosis, warts, benign intradermal nevi, vesiculobullous lesions, malignancies like squamous cell carcinoma, basal cell carcinoma, lentigo maligna, which is a type of malignant melanoma. To repair scars also it can be done. If there are superficial scars, you can take out the scars. To repair dog ears, superficial pits, irregular elevations of the sebaceous skin on the nose. So these are the indications wherein you do the shave biopsy. Advantages of shave biopsy are it is a quicker procedure which requires only very little training to do the biopsy. Simple procedure with minimal scarring, it will heal, and it gives good cosmetic results because the approximation of the wound is very good, and it also has good hemostasis, that is blood loss is not too much. The disadvantages being deeper dermis and fat is not sampled here, so if the pathology lies deep in the dermis and in the subcutaneous tissue, that cannot be viewed, and if the deeper part of the dermis is involved, then it can lead to depressed scar. So these are the two disadvantages of shave biopsy. So this is how a shave biopsy is done. You can see the blade held parallel to the skin surface here, and the lesion is scraped off, right? So the superficial defect is left behind. Again, a shave biopsy, anesthesia is given in this picture, and then the blade is parallel to the skin surface, and it is taken out here. Punch biopsy is another method. Punch biopsy is the most commonly done biopsy by dermatologists. You'll get a probe which has a punch attached to it, and this punch will go inside the skin and cut through the skin. So a cylindrical cutting instrument available in varying diameter. So this diameter of this thing can vary. It can vary from 2 to 10 mm in size depending upon the lesion and depending upon the size the site you're doing the biopsy. Okay, it will take the tissue from the epidermis. So from the epidermis until the subcutaneous tissue is biopsied here. So all the layers are basically taken into consideration here. If you're doing it on the face to reduce the defect, 3 mm biopsy size is used. Best that you can use is the 4 mm biopsy size. Otherwise, instruments you need for biopsy are you need a biopsy punch, iris scissors, skin hook, adsense forceps, suture, and needle holder. So here asepsis is followed, local anesthesia is given, stretch the skin along the Langer's lines with the left hand, and then punch is taken perpendicular to the skin. So if this is skin surface, it is done perpendicularly. Monodirectionally it is rotated. So this punch, you have to hold it in your dominant hand and try to rotate it monodirectionally while going deep inside the skin. So you keep rotating it and keep going deep inside the skin until this whole part of the instrument goes inside the skin, reaches the subcutaneous tissue. So it has to travel to the epidermis, dermis, and subcutaneous tissue, and then when you reach the subcutaneous tissue, you'll feel this giving away. Hold the tissue carefully with forceps and cut it with scissor or blade later. Do not crush it to damage it, and place it in formalin for transportation. Hemostasis can be achieved by suture, or you can just dress it with antiseptic ointment. It will reduce. So indications for these would be skins within deeper component like in TB, leprosy, panicleitis, nevi you can do, or any other skin condition also you can do this. Advantages, it's very easy. It's both diagnostic and therapeutic. If the lesion is a small size, then it's both diagnostic and therapeutic. Heals without scarring, less infection, less bleeding. Disadvantages would be pain and discomfort, of course. If the periosteum is accidentally hit, then it can cause pain and discomfort. Material may not be adequate. The biopsy material may not be adequate for evaluation. It may not include the deeper tissue sometimes. So these are the punches here. These are the stainless steel punches, and these are the disposable punches that you get. So this whole length of the punch should go inside the skin so that it will reach the subcutaneous tissue as well. So these are the instruments: the forceps, the scissors, the punches, and the insulin syringe for giving anesthesia. This is the anesthetic agent, and this is the formalin that you store it in. So clean it and give the injection. Then you take the punch, mark the area, take the punch, take out the punch with the help of the forceps here. Take it out, do not crush the tissue, place it in the formalin and dress the wound. Again, a lesion here is biopsied with a punch and it is sutured later. Next biopsy is excision biopsy. Excision biopsy, the entire lesion is biopsied here. It is both diagnostic and therapeutic here because you take out the whole lesion. So therefore it is both diagnostic and therapeutic. Instruments we use here are the BP blade, the scalpel handle, AdSense forceps, skin hook, side scissors, needle holder, suture and marking pen to mark the site. Procedure is you have to mark the margins, that is 2.5. This is a particular lesion. The margin of the lesion also has to be taken if it is pre-malignant, malignant, depending upon that. And the 2.5 to 5 mm can be the diameter around the lesion. Okay. A local anesthesia is given and an ellipse. If this is a particular lesion, then an elliptoid incision around the lesion is basically taken. Okay, you have to first start from here, from the apex, and then go towards the other end, reach here, and then again come towards the other end. So the lesion has to be an ellipsoid lesion, including the particular tissue that you are taking for examination. Hemostasis is achieved with suture, or you can give an antibiotic dressing. It is done for Neva assist, BCC, SSA. Full thickness is obtained. In toto removal is done so that there's no risk of recurrence or metastasis. It is both diagnostic and therapeutic, but it needs great expertise because you're taking an incision here, requires sutures and complications may occur. So here is a lesion. So elliptoid incision is taken here and the tissue is taken out and sutured back in this. Incisional biopsy is also known as wedge biopsy, wherein if this is a particular lesion here, part of the lesion is taken into consideration here. Okay, wedge shaped part of the lesion is taken for biopsy. The active edge of the lesion is taken for biopsy with the surrounding normal skin as well. Okay, it can involve dermis, epidermis and subcutaneous fat. It is usually done to detect the lateral extent and also the deeper extent. Both the lateral extent and the deeper extent of the lesion can be known by this. Spindle-shaped active edge is taken and extend from the normal skin towards the center of the lesion. Snick biopsy, a small superficial sample of skin containing epidermis and part of superficial dermis is taken. Tiny fold of skin is raised with a needle tip and it is cut with a sharp forceps. Skin surface biopsy, it is used for inspecting stratum corneum. It is done by removing strips of stratum corneum. What you do here is you take 2 drops of cyanoacrylate adhesive and it is placed on the skin surface for rapid bonding. Now a clean glass slide is taken, is applied over it firmly and held in contact for few seconds. The slide is rolled off the skin surface, removing a strip of the stratum corneum, then is fixed on, stained. So indication is for seeing scabies, mite, dermatophytosis, candida species, Petrospora mobile, erythrasma, dermodystrosis. So all of this can be visualized. So here you're taking a glass slide and putting the cyanoacrylate on top of that and pressing it on the lesions. And then you stain it and see it. Curette biopsy, if there's a friable part of a lesion that is scooped, with the curette it is scooped and without any local anesthesia it is done. Simple, safe, inexpensive procedure with adequate sample is obtained here. No details about the depth and lateral extent. So basically if this is a particular lesion, a friable lesion which is hanging on top of this, you just take a curette and scrape it off, that's all. Okay, but the extent, the lateral extent or the deeper extent is not obtained here. So this is a curette you use or scoop it out. It can be done for comedones. So here you can see a wart removal being done here. Local anesthesia is given here and then it is curetted out and it's gone. Mucosal biopsy, just like how you do biopsies on skin, mucosal biopsies also can be done. Example, in the oral mucosa, you do shea biopsy if it is superficial growth in vesicles. Excisional biopsy can be done for small benign growths. Incisional biopsies for leukoplakia and suspected malignancies. Local anesthesia with adrenaline is again used here to reduce bleeding. Also, Excision forceps can be used on stage, sutures can be used to reduce bleeding for oral biopsies. Again, one thing to remember is it should not be given in the lips. It's better avoided. This combination is better avoided in the lips. Local anesthesia and adrenaline combination. No dressing is needed. Antibiotic cream and anti-inflammatory treatment is enough. So here you can see the use of Excision forceps to basically obtain a bloodless field in removing this particular lesion, and it's removed and sutured. Scalp biopsy, it's very uncommonly done because of the excessive bleeding that we see, because scalp is a vascular structure. It is done in cases of alopecia, which is due to scarring or non-scarring types of alopecia. You have to trim the hair before the procedure. 4 mm punch biopsy is obtained. Incision biopsy can be done. One horizontal section. After you obtain the biopsy, the technician has to be told to do horizontal as well as vertical sectionings of the biopsied material. Horizontal sectioning is done at the dermoepidermal junction. The vertical section is used to visualize the epidermis, the entire hair follicle inflammatory infiltrate. So to see all of that, vertical section is required. Horizontal sectioning is done to visualize hair follicles. The quantitative evaluation of hair density is done, follicle unit number, anagen to telogen ratio, terminal to vellus hair, diameter of the hair shaft. All of this can be seen with horizontal sectioning of the hair shaft. With vertical sectioning, the entire hair follicle can be seen with inflammatory infiltrate. A nail biopsy also is done for certain nail diseases. So the finger anesthesia needs to be given by digital block with lignocaine without adrenaline again, because again it's a finger and ischemia can be seen with if you use adrenaline. That has to be avoided. Nail plate biopsy, nail matrix biopsy, nail bed biopsies can be done depending upon the indications. For nail matrix biopsy, nail avulsion is done first. That is, the nail plate is taken out and then a horizontal elliptical incision is done. So if this is the nail matrix will lie here. So the nail plate has to be removed first and then the horizontal elliptical incision has to be made here. Side effects includes bleeding and pain, nail dystrophy. If the nail matrix is damaged too much, that can cause nail dystrophy. So indications would be for nail plate biopsy, it is done in onychomycosis, that is the fungal infection of the nails. Nail bed biopsy is done in diseases which involves nail bed pathology, like in psoriasis, 20 nail dystrophy, melanoma, glomus tumor, Bowen's disease, subungual wart. Nail matrix biopsy is done with lichen planus, psoriasis, 20 nail dystrophy, and melanoma. Post-biopsy considerations, specimen has to be placed in 10% formalin and seen under light microscopy. For immunofluorescence studies, it is placed in Michael solution or phosphate buffered solution. Wound dressing needs to be occlusive or semi-occlusive to ensure better healing and faster healing. Dressing is removed in 24 to 36 hours and cleaned with soap and water, and then antibiotic cream can be applied. Sutures, if it is placed, can be removed in 7 to 10 days. Complications of biopsy. Hypersensitivity to local anesthesia can be sometimes seen. Discomfort with the administration of LA, like stinging, pain, and burning sensation. Bleeding and hematoma formation. Infection with Staphylococcus, Streptococcus, and Candida. Allergic reactions to the topical antibiotics. Irritant reactions to the tapes. Keloids and hypertrophic scars. Not very severe, but that has to be kept in mind.